There it is. Here we are. I am joined, Bono's Health here, joined by Professor Evangelos Papas, my old professor. He's been on this show a long time ago. We touched base and said, let's get back to it. We were talking about the concept of ACLs, and he does a lot of research on ACLs. I'm going to let Professor Papas, joining us all the way from down under, the land down under. Are you in the University of Wollongong?
No, I'm at home at the moment.
Oh.
But yeah, so great to be back and see you again and hear about all your success. We do go a long way back at Long Island University when I was teaching you. And now you are out west, and I even further out west in Australia. So that's how life brings things. We did speak probably a couple of years ago or a year and a half ago, and a lot of things have changed in the world of ACL research, which is always wonderful and exciting, Bo. We have just in the last couple of months, we have clinical decision-making tools, which we didn't have before in the systematic way that we have them now. So we just published a paper that was led by Andrew Gamble and Josh Zadro here at in Australia from the University of Sydney. So Andrew is doing his PhD, and he published a pediatric clinical decision-making tool that I think will be very useful for the patients and the pediatric patients and their families who are trying to sort through the evidence, which is always a very tricky thing to do, even for people like you and me who spend our lives reading about those things, but particularly for those who just are faced for the first time in their lives with an ACL injury, and now they have to make decisions about how to treat it. And also an online tool that has been developed by another group here in Australia from the University of Melbourne, from Stephanie Philbay. And this is for the adults. Again, these are tools that we're hoping to grow, to further develop as more research is being published. And we really believe that this will be valuable tools for the patients and the families as they're trying to make decisions, because it is a serious injury. An ACL injury can be a life-changing injury. And of course, there are people who have wonderful outcomes after it with either conservative or surgical treatments, but there are also many who don't. They have to stop playing the sports that they love, or they develop symptoms, knee symptoms, and osteoarthritis at a relatively young age. So all these are things that we can discuss today, Bo. So I'm happy to keep speaking, but or if you want to ask questions.
Yeah, let's break it down a little bit for folks. And I looked up the last time you were, it was about 2 years ago, and then we did another one 3 years ago. So this is our third on this show. Let's talk couple of definitions real quick. We'll talk about what the ACL is for anyone who might want that definition, who might be popping in here just to get a little better understanding of the anatomy. And then when you say the pediatric tool, just for that, is it under age of 18 is considered pediatric? Right. Just to be clear. And then adult there above. And then when you mention kind of the impact on people's lives, as the example I give when I see patients and talk about these concepts is it's about a 1 year full recovery, right? Before you can, there's obviously a little bit accelerated, there's a little bit delayed responses, but about 1 year when I say you get back to like 100%, and even after that, even professional athletes, we see with all their resources at their disposal, sometimes they get rushed back too fast, and then they're a full year out, and they're still kind of struggling to get back to where they used to be. They might still have the ability to do all their things, but they might not be at that level where they once were. As a New York Jets fan, most people might not get this reference, especially in Australia. But if anyone's listening from Australia, but Breece Hall, yeah, he came back. He was able to make a lot of the same cuts he was making. Then he doesn't have that down the field speed. So that was the joke. But by the end of the season last year, he was able to kind of catch up on that. So very cool to see. But for most folks, not professional athletes, we're talking about a 1 year recovery, and about $50,000 is kind of, I think, the number that I've heard out there of total cost to the insurance company. You might not be paying that out of pocket, depending on your insurance. But, time lost, again, we're talking about this pediatric population. And again, correct me if I'm wrong on this statistic, that in the United States, I believe high school female soccer players tear their ACLs at about a rate in the 40 percentile, 40% of high school, which seems absurdly high. But 40% of female high school soccer players in the United States tear their ACLs. Does that sound right to you?
I haven't read that, but that sounds, quite fascinating.
It sounds yeah.
Yeah, well, obviously, the more you play, we have to keep in mind that, if you don't play the high-risk sports such as the soccer, the basketball, the volleyball, and so on and so forth, then the risk of tearing your ACL is quite low. But yeah, and we know that for actually more than 40 years now, that female athletes are at a much higher risk of tearing their ACL. In soccer, probably 2 to 4 times more, which is quite large for epidemiological standards than their male counterparts. So yeah, to pick it up from the beginning, maybe from the very beginning, as you mentioned earlier, maybe starting with me. So I'm a professor at the University of Wollongong, just south of Sydney. And since I was at LIU and teaching you and the other wonderful group there, I have been doing research for the last more than 20 years now, actually almost 25 years on ACL injuries. And of course, that this field has grown tremendously. We have a very large team here together with Rick Lovell at the University of Wollongong and Matt Whalen, who is the physiotherapist for the Socceroos and the Oileroos, the national soccer teams here in Australia. We do research on ACL injury prevention and treatment. So the anterior cruciate ligament, or the ACL, is about the size of the little finger. It's a piece of connective tissue that connects the tibia, the medial part of the tibia and the front part of the tibia, to the femur. And it does quite a few things. The main thing, yep, that's right.
It's in there. I do have my scar show
that's
off.
Right. That's right. That's right. That's another thing you and I have in common.
Yeah, we both had ACL reconstructions.
We both had ACL reconstructions.
Was that part of your? I don't think that was the impetus for you to push that. You had your ACL long after.
No, I had my ACL injured just a couple of months before defending my dissertation on ACL injuries and how to prevent them, which is very ironic. Yeah. So yes, it is a very important part of the knee ligament for the health of the knee, and it prevents the tibia from sliding forward and also from rotating too much. So how can the ACL tear? Usually landing from a jump or cutting, changing directions,
or somebody falling on you, which is what happened to me.
That's right. It could be a contact injury, and in some sports like football, that is not uncommon. But in the majority of cases, it is a non-contact injury, meaning that the athlete is doing a maneuver that they have done multiple times before, frequently thousands of times. And this time they just hear this dreaded pop, and they realize something serious has happened, and the knee starts swelling, within the next couple of hours. It feels unstable, it feels awkward, it feels weird, it feels that it's moving too much. I have an MRI. There is a test that is quite good at diagnosing this tear, where you stabilize the femur and you move the tibia, the shin bone, forward, which is exactly the motion that the ACL prevents. This is called the ligament test. And when you see that the tibia is translating more than the other side, and there's no end field, so there's no firm stopping at the end of this motion, then you're pretty sure that the ACL is torn, and an MRI can confirm that. So this is, in a nutshell, what is happening.
Can I jump in, because I have a clinical query for you, because I had a patient recently in the clinic that he didn't have a diagnosed ACL tear. He had knee pain, and I just, for whatever reason, it was the second time I'd seen him, and based on what he said, his knee had been giving, which to me, I was like, let me just check, and I just checked his lockman. It had no stop. Right. I thought I pulled it like a full foot. It was incredible. I'd never, and I called over one of the newer therapists that I don't think had seen as many such tears. I've seen a decent amount in my career, and so she did the same thing. And I'm like, it's not me. There was no stopping. He ended up I was like, you need to go get an MRI, or talk to your surgeon, because he had other stuff going on. And so, but the MRI showed no tearing. How are you familiar with a lockman being so positive it would be a false positive, I guess.
Yeah, yeah,
How
that's
often is
right.
what's the do you know a percentage on that? I was blown away.
Yeah, no, that's quite rare. So thanks for sharing these. That's a nice clinical pearl. But he had a firm stop on the other side. Was
Yeah,
it just okay?
yeah,
Wow, that is indeed very rare.
yeah.
Um,
I went through like
hmm,
what
well,
and exactly. Yeah, I checked the other side. It was not, and because it was his description that his knee was giving out, and there was just nothing else on imaging. So it was I don't actually know what ended up being the true case or whatever. He was not my patient. I only saw him that 2 times,
mhm,
but so yeah,
I
I don't
see.
know. I appreciate you kind of confirming that. That's incredibly rare.
Yeah, yeah, no, very rare to have something like that. I mean, it is the reason I asked about the other side is that it's not uncommon for athletes to have a lot of laxity.
Hmm.
So that can certainly be confused as a positive Lachman. I mean, the other possibility is a PCL tear, which
Hmm.
then is quite tricky because then it allows the tibia to sit further posteriorly, further back on the femur. So when you do the Lachman, it appears as it moves too much, but only because it starts from a very different baseline. But in this case, there is a firm end feel, and the PCL, people can cope with the torn PCL much more frequently than they can cope with an injured ACL. But of course, the other possibility, Bo, here is it's not the Lachman only that has
Hmm.
false positive; it's the MRIs too are
Yeah.
not 100% perfect.
Right.
So the diagnosis is made in a combination. I mean, for most patients, it's a much more clear diagnosis. They know exactly when they did it. They felt a pop in the knee. They got swelling within a couple of hours. The Lachman is positive, and the MRI shows that there is an ACL tear. But yeah, there are these zebras that we call,
Yeah.
those
Yeah.
those more trickier clinical situations where the diagnosis is a bit trickier.
While we're in that ballpark,
Hmm.
can I ask? I think around the time again I graduated, we our time together was 2005 to 2008 at LIU. Just for the listener, and pivot shift was becoming much more popular. Pivot shift
Hmm.
test. My understanding is it is now less high standard testing, specificity, sensitivity in the research. Can you confirm, deny the usefulness of that pivot shift to some extent? Because
Sure.
I've kind of I've somewhat removed it from my toolbox somewhat. And talking to some of the surgeons that I've been dealing with recently, they
Hmm.
also aren't big fans of it. So
Okay.
just
Yeah.
just curious what the research says.
Yeah, so the pivot shift test is another test that the physical therapist or the doctor can do, and that tests more for rotational instability of the knee, which is the other motion that the ACL prevents. The pivot shift test actually is a bit more predictive of who needs surgery based on
Mm,
some research. It is a technically much more difficult test to do, but also to grade. But also much more uncomfortable for the
hmm.
patient because the patient feels that the same mechanism of injury, because in essence, when the ACL is torn, that's a subluxation of the lateral tibial plateau. So the tibia translates too much forward and also rotates internally. So the lateral tibial plateau is actually subluxing anteriorly, and then as after the ACL is torn and the athlete realizes that they did something wrong, they extend the knee and then it reduces back into place. But the pivot shift test, in many ways, it replicates that same mechanism of injury. So yeah, again, it is a test that I think some of the more experienced surgeons, at the Hospital for Special Surgery, for example, they really like this test, and they see lots of patients with ACL tears all day long, so they're really good at doing it. But yeah, I rarely do that test simply because it is technically more
Mm,
challenging, and because it also, for the physical therapist, you want this rapport with the patient, you
hmm.
want them to trust you, and then this test is similar to the apprehension test for the
Mm.
shoulder, where you try, or the patella apprehension test, where you try to replicate the subluxation. So I rarely use it. Um, So I guess that's in terms of the diagnostic side, what the listeners need to know, that most of the times it is pretty straightforward to make the diagnosis, but also it's something that cannot be ignored. I've seen quite a few patients, and please share your experience here too, Bo, who are in denial. They feel that it will be it's nothing serious, and I have seen patients who had an ACL injured, or actually in one case is both ACLs injured 25 years ago, and they've been skiing and dancing and doing all sorts of sports. So these are the coppers, and they didn't have surgery. They had a very good outcome with rehabilitation alone. But also there are many who really need a more structured rehabilitation program, or changing, and that's the other thing that I will have the opportunity to speak, changing some of the sports that they do. So that's a discussion that I think that as clinicians, both orthopedic surgeons and physical therapists, who have failed to have with our patients, because and the example like giving here is that if you have a heart attack or a near heart attack, right, and then you're taken to the hospital, and then they put a stent on you, and then they say, okay, well, now you have to see a nutritionist, you have to look at your lifestyle. They don't put as a goal, we should, our goal is that you go back and you eat, steak 3 times a week, because, part of this may have been why your arteries are blocked, and you ended up having a stent. Well, for the ACL, very frequently we put as a goal, and of course our clientele, the patients, they are very young and they want to keep being active, returning to the same sport. So that is frequently in research studies, did the patient return to the same level and the same sport as before the injury? And this frequently is demonstration of a successful outcome, but at the same time, should we recommend this for all patients? And I would argue here, and this may sound a bit blasphemy in this field, Bo, that one of the first discussions that we should have with the patients, especially for those patients who had multiple ACL injuries, right? Because I guess you and me and many of the physical therapists who specialize in this field, we see repeat offenders, right? We see patients who had an ACL, maybe surgery or not surgery, and then they kept injuring that knee, either the graft or a meniscal tear or the other side, and so on and so forth. So we do know that not everybody's at the same risk for ACL injuries. So I think one discussion that we frequently don't have with our patients is that, are you better off switching to a different sport? Because you don't want to have an 80-year-old knee when you're 30-year-olds. And in my clinical practice, that has, back when I was practicing in New York, those patients have been some of the more difficult ones, right? And it's not uncommon. They had an ACL injury when they were in the late teens, early 20s. Frequently, they had a reconstruction. They went back and playing sports. They had, maybe a meniscal tear a bit later. And now they're in their early 30s, and there is plenty of research that shows that, and they have symptomatic knee osteoarthritis. We do not have good tools for them. We don't have good solutions for them because they're too young to have a total knee replacement for a variety of reasons, but also because the level of activity that they want to keep is not congruent with their knee replacement. And in between, having a knee replacement for a severely osteoarthritic knee, and keeping active, there's no good solutions in this range. So ACL injury prevention is very, very important, and there are injury prevention programs out there that we have demonstrated, and others around the world, that they are very, very effective. The FIFA 11 Plus, the Perform Plus that was developed by Matt Whalen here in Australia, practically all of them, they use quite similar elements, and they have shown to be very effective in preventing these injuries, particularly for those high-risk athletes. So this is one element that we have to keep in mind, and keep pushing and investing more. Some countries, they do this better than others. But also when an athlete is injured, particularly if it's not the first knee injury that they have, I think we should start having these difficult discussions, because they are indeed difficult discussions to have with young athletes about potentially maybe basketball is not the sport sport that you want to keep playing, simply because it increases the risk of re-injury and then down the road of osteoarthritis. And there's nothing wrong with swimming and cycling and fitness activities that are more knee safe. So yeah, in the rest of my career, this is what I want to keep doing and pushing for, injury prevention, and then having these difficult discussions and educating patients, because we don't do that very well. We rarely speak to them about the long-term outcomes after an ACL injury. Many athletes, they still believe, and sadly some surgeons are pushing that, and it's wrong, that having a successful ACL reconstruction prevents knee osteoarthritis. And the research does not support that at all.
No, my understanding, even when I had my surgery in 2008, December 2008, and but I believe I've looked at it recently, has not changed much, that any ACL reconstruction has an 80% chance of developing arthritis within, I believe, 30 years, I think was the number. Something like that.
Yeah,
So,
sounds.
and I don't think, from my understanding, the research hasn't changed much in.
No, we have done a very poor job in decreasing ACL injury rates. Actually, as a matter of fact, they may be going up, and this may be that people are more active and so on.
That's what I've seen for sure. Maybe just American bias there, but definitely a significant increase in ACL rates, tearing rates.
Rates, but also, we have made no progress in preventing knee osteoarthritis after an ACL injury. As a matter of fact, the research, if it is pointing in one direction, it's pointing in the direction that for those who had an ACL reconstruction, the risk of developing osteoarthritis may be slightly higher, but definitely not lower compared to those who choose a conservative path. Yet, again, and we did a study, again, Andrew Gamble did a study where we looked at the quality of the information that is out there on the internet, including on the websites of orthopedic surgeons and other healthcare professionals that, that patients really trust, and they read this information, and yet quite a large number of these websites, they still propose the idea that you should have an ACL reconstruction to prevent knee osteoarthritis, and there is absolutely no evidence to support this.
I actually just did a quick Google search just to see what came up right before we went live, and it was an AI generated Google, whatever they're doing now. We're in the early stages. So if you're watching this 5 years from now, you can laugh at the elementary level of AI, I guess. But it said similar outcomes for doing the ACL reconstruction and not, except the only caveat they kind of added was 3 to 6 months of supervised exercise required for the conservative approach, the non-operative approach, in order to get those similar outcomes. I did not see if that's 12 months later, 5 years later, but there's something there. I do want to ask you real quick. I saw a few studies come out recently about if it's not a fully torn ACL, there's still some fibers connected, some kind of regrowth. Is this something promising?
Yes. Yeah, definitely. Okay, good. So a few important things to discuss. And just to take it a step back in our discussion, Bo, you mentioned earlier that it is a year-long process after an ACL injury, whether you do go down the conservative path or the surgical path. At this point, we have very good evidence that nobody should be returning to full competition earlier than 9 months after an ACL reconstruction. So there are studies that show that the risk for every month earlier than the 9 months that someone is returning to full sports, the risk of re-injury goes up. Keep in mind that most of the re-injuries to the ACL happen within the first 2 years. So waiting there is really important. So that is one thing. The second thing that goes back to the AI search that you did is conservative versus surgical treatment. In the last couple of years, and that's a departure from the evidence that we had before that, we had 3 studies that came out, 3 high-quality randomized controlled trials, which is the pinnacle of research design when it gets to answering these questions, where they randomized people who tore their ACL, and they just randomly assigned them to one of the two groups. So one group is you go to have surgery, early ACL reconstruction, which is the particularly in the United States and in other countries, it is frequently what the advice that the patients get. And the other half of the patients, you have the option of having the ACL reconstruction at any point, but we want you to first do a structured rehabilitation program. So the oldest of these studies is the Canon study that just came out, I believe, with a 11-year follow-up. Out of Scandinavia. Then there's the COMPARE study out of the Netherlands, and then more recently, the last one, and probably with the catchier acronym, is the ACL SNAP study out of the UK. All of them, slightly different in terms of the inclusion criteria, but, and we're not going to go into the methodological details too much. But roughly what they did is they randomized the ACL injured patients into one of these two groups. And there are some really important findings there. First of all, and this is surprisingly consistent, everybody who has made the mistake of looking into the medical literature understands that finding consistency there is not quite common. But one of the things that came out of all three of these studies is that in the conservative group, so the group that said that they were randomized into, just have rehabilitation and then surgery at any time you want, half of the patients ended up having surgery. Okay. That doesn't mean that they did better after they had the surgery. You cannot undo the surgery when you have it, but it certainly means that half of the patients in this group, they were unhappy enough with even after the structural rehabilitation program, with the function of the knee, that they decided to try having an ACL reconstruction for whatever reason, but we can safely assume that they were not very happy. If the knee was fine and they could do all the things that they wanted, they would not have surgery. So that is one thing. The other thing is that, and that is, there's a bit of variation there between the studies, but the differences between the groups were quite small. Okay. So it's not that the ACL reconstruction, particularly in the Canon study, actually in the Canon study, the outcomes were almost identical between the two groups. They compare study slightly favoring more the ACL reconstruction group, and then the ACL SNAP favoring even more the ACL reconstruction group. But the differences, when you look at the magnitude of the differences between these groups, is quite marginal. Of course, having a surgery, I was reading on LinkedIn recently, which is a wonderful place, for professional education and exchanges of
the opposite of X.
The opposite of X. Somebody posted about the disclosures that that orthopedic surgeons provide to patients, and they said that an orthopedic surgeon in the United States, as he consents his patients, he looks them in the eye and he says, orthopedic surgery is dangerous. You could die or worse.
Or worse.
So there are risks with surgery here. Obviously, ACL reconstruction is not as extensive or as risky as some of the other surgeries. But there are infection. There are bad things that can happen with these surgeries too. So I think these field, it is fascinating to see all this interest and the high quality evidence that we're getting now. It's still an evolving field, as you would think, but enough for us to create clinical decision-making tools that now are available to the public, as I said before. Now, the other fascinating area, and this is a game changer in this field, and that again is very recent, is the cross brace protocol. So that, here in Australia, that has been known for quite some time now. So there is an orthopedic surgeon who has had this theory originally that, well, if you brace the knee immediately after the ACL injury, that approximates the two ends of the torn ligament. Because we know from laboratory studies that the ACL has very strong healing capacities, right? Just like any ligament, because we rarely do surgery on the MCL now. the ligament that is on the inside of the knee, the medial collateral ligament. Again, that goes, quite a few decades back. But when I first came out of PT school, I would see quite a few of MCL repairs, just because they thought then that was the best treatment for this ligament. But then research showed that actually, for the vast majority of these patients, conservative treatment of the MCL has exactly the same, if not better outcomes. So now, particularly isolated,
for a complete tear, even
for a grade 3 tear, if it's an isolated injury, then the treatment of choice is a conservative treatment. In the multi-ligament knee, if there is an ACL, PCL, and MCL, again, probably they try the conservative treatment initially. If there's still residual laxity, they may repair or reconstruct the MCL. But again, in the vast majority of patients who had an ACL and MCL tear, conservative is the right treatment with very good outcomes, actually. The ACL, when you take it out of the knee and then you look in the laboratory, the cells there, they're trying to repair quite frantically. So there is a lot of healing potential. But it doesn't work in practice. So what this doctor proposed is that, well, if you brace the knee and then protect the knee, and it is a quite strict bracing protocol. So they brace it at 90 degrees for a month, and then at 60 degrees for a month. And then in the third month, they gradually allow, still protected, but they allow progressing towards more extension. So there are risks with that. There is DVT. So most of these patients, they go into anticoagulant medication and so on and so forth. Very anecdotally, I had two people that I know. One is the daughter of one of my colleagues from the University of Sydney, and the other one is a collaborator down in Melbourne. And both of them, they had this protocol, and they had repeat MRIs that showed some healing. There is a paper that was published by Steph Philby and her group on the cross-brace protocol at BJSM just a few months ago that shows a very high percentage of healing with the success with this protocol, and success was defined as healing in the MRI. I think something more than 90% of the patients have shown some form of healing. I'm not as bullish about this. I do believe that a lot of patients will find benefit, and we still don't know. I think that will hopefully be the next step, is to a priori select those patients who's a better candidate for this protocol. But I would be very surprised if 10 years from now, 90% of the patients having a good outcome with this brace protocol. But I've been wrong before. Hopefully I'll be wrong again. But my sense, if I had to bet on one side, is that the cross brace protocol is here to stay. There are patients who have shown very, very good healing and very good clinical outcomes. Still very early stages, they will have to be cautious with these things, but also I'm cautiously optimistic. But I believe that the subgroup of patients who had an ACL tear will find a lot of help with this cross-brace protocol.
One thing I've seen a little bit, and again, I mentioned time I graduated, started my career 2008, platelet-rich plasma into the ACL repair site. I've seen that do almost nothing. I believe the research has kind of backed that up over the years. It's definitely pretty rare where that's practiced that I've seen. Is that kind of where do you stand on that? Just wanted to throw the platelet-rich plasma, because it seemed like a trend that did not stay. I still see a little bit of it, but just checking with you just to educate the listener there.
Yeah, these PRP in general, for musculoskeletal injuries, there was a lot of hype initially when it did come out. And I have to say that my opinions on this have shifted over the years, if not the last few months. So largely, when you look at the studies, PRP is ineffective. Just the totality of the evidence there is pointing towards a small to no effect. However, by speaking to experts in the field and some recent conferences that I attended, there is a big difference in the concentration of the PRP. So a lot of the studies, some of them, they used a high concentration and they tend to show better results. The majority of them, they used concentrations that are not enough. They're not at the recommended level for producing that clinical effect. There is very little on the ACL work. So, again, this is another area that if it works, wonderful, right? Who wouldn't want to have an injection and then increase, multiply the success, the possibility of a successful outcome? I think it would be wonderful if it works. But I think what we need is more high quality evidence with the right concentration of PRP, with the right levels of PRP. I work with an orthopedic surgery group here that they believe that this works at when it's done appropriately. But again, that's an area. There's very little on the ACL world to demonstrate that. But the other area that is also very exciting, and we're still waiting for long-term studies there, is the BEAR implant, which is the Bridge Enhanced Augmenting Repair, I think is what the acronym stands for. And that is out of Martha Murray's group in Boston, where they select the patients. It has to be a recent injury, because, if it's a chronic injury, the potential for healing quickly drops. But in an acute injury and in young patients, they, instead of reconstructing the ACL, which is a much bigger surgery where they have to take a graft, either from somewhere else in the body, usually an autograft or an allograft from a cadaver, and they drill tunnels in the tibia and the femur, and then they stabilize, pass the graft through there, trying to replicate, in essence, the ACL. And then they use screws to stabilize it. But the BEAR is a direct repair, where they arthroscopically go into the knee joint, they find the two stumps, the two ends of the ACL, and they stitch them back together, and then they put a bridge to keep it in place. There was a study that was published about a year and a half ago, or a couple of years ago, at the American Journal of Sports Medicine, that showed that it's not worse than the ACL reconstruction. So again, exciting possibilities there in the ACL world, but also we need them, because overall the outcomes at the moment are just not great.
Yeah, I was pulling up my my ACL. I don't know if this will show too well, but there's my scope. There's the crab meat, the two stumps. So they would take that stump and connect it to that stump.
Exactly.
Yeah, very cool. Yeah, a lot of exciting stuff going on. So for somebody, it can be a little overwhelming, I think, for somebody who tears their ACL. They happen to stumble upon this podcast here, and they say, they Google things, right? Everyone Googles things, or they ask their friends who've been through it, or they ask whatever medical professional they might know. That doesn't always mean it is the best level of evidence, which is kind of, you could be in that circle of friends. Thinking of a patient right now, she might be watching, actually, 50-year-old, very active mountain biker and motocross biker, tore her. You were talking about the MCL, ACL. The surgeon actually decided to do a two-stage surgery. Did the MCL first, wanted to get her full range of motion for the ACL 6 weeks later. So they had a 6-week gap to do the second surgery. She's really happy so far with how that turned out. She had a very particular friend also that similar kind of injury. I don't know if he had the MCL as well, but he ended up doing the conservative approach, non-operative. And he's very active. He did whatever research he did. I believe he might have included stem cells as a little bit of a healing. And there's also actually I am curious about this one, because this is another one I hear a lot. I'm curious on the research. The peptides, the BPC 157 has been very popular. There's a bunch of other peptides. It seems very black market-ish, very kind of guy. Oh, you got to meet this guy in a van in an alleyway. I've literally heard that out here in Colorado. People kind of, and I mean, the guys have websites and things like that, but that's kind of what it's like. Yeah, I'm gonna meet him, and he's gonna it's a weird, shady kind of thing. But yeah, I don't know the research around peptides and their impact, maybe not on a fully torn ACL, but in terms of injury healing, there's some hope that it's helpful. It seems to help systemic healing. So I don't know if you have any thoughts on peptides.
I know nothing about peptides or meeting people in the van and having an injection in your knee in the middle of the night, but it doesn't sound like something that we would recommend. But yeah, I haven't followed the literature on peptides.
Okay, I might have to do my own personal. No, I'm not going to do any. No, but a lot of people, I've heard people swear by it. The Joe Rogans of the world and that kind of thing talk about these kind of things. So, but yeah, I was curious if it made its way into, again, for folks listening, this is a real professor. This is a man of science. I think it's important to have that distinction. I think we get lost in some of that. And I think the part I was starting to head to in terms of this conversation is, and I want to be respectful of your time. I know you were also, might need to go do some more Epley maneuvers to yourself. But or is it Dix-Hallpike? Are you doing Dix-Hallpike or Epley? So the thing that we're aiming towards is science communication. That seems to be, if a layperson was listening to all these acronyms you're throwing out there, I think most people could follow it. You're doing a very good job. As one of the reasons I think you were one of the top and one of our everybody's favorite professor, other than your charming accent, is the ability to kind of communicate that science, the research over to make it more palatable. I think that's a huge piece missing from the Googles, the AIs, all that kind of stuff. I'm very curious where this goes. With podcasts as well, these more long form conversations where somebody's tuning in saying, hey, again, I tore my ACL. Should I or should I not have surgery? And again, we can't speak to every single person. We cannot give medical advice, but we hopefully have provided already some guidelines of maybe these are the things that'll help you. And again, you did state it pretty clearly. There's no real solid research to say having your ACL reconstructed is necessarily better than not having it reconstructed. The outcomes right now, in the best evidence we can look at, are that the outcomes are similar. There are certain factors that might apply to that, depending on what the sport you want to continue with. I had another patient, actually, very ironically, I mentioned this to you on our LinkedIn messages, was I think the day we agreed to do this podcast, when you booked it on my calendar, and you mentioned that you wanted to talk specifically about this topic, it was the first non-op ACL I had seen in the clinic, in a pretty busy clinic. And long story short, 30-year-old doesn't want to be very active, might want to get pregnant at some point, not fully committed to that, and was like, yeah, I don't know that I want to go through a year-long process and the cost and all that associated with it. I think, can I do it non-op? And the surgeon, I think, ultimately convinced her to do it. I was not super involved in that conversation. I kind of gave her my 2 cents in the 1 or 2 sessions that I did see her, but I was like, yeah, if you don't want to be super active, again, the research, to my understanding, and we're kind of talking about here. So yeah, science communication, I appreciate you being on here, taking the time to talk about these complicated topics, trying to simplify it a bit. And when we can go deep into a specific topic like this, I think it's super useful to the folks, somebody out there, again, who might have torn their ACL and deciding what to do, hopefully is a thing. One other big question in that exact conversation, if somebody is saying, I am going to do the surgery, you mentioned the cross brace, you mentioned the bear. I think those two are probably relatively new. The biggest question, and I believe I'll give credit to you, going all the way back to the 2000s, let's say 2007, of saying the number one question to ask your surgeon is, how many of these do you do a year?
Right. That's true for orthopedic surgery, if not for all surgery in general. But yeah, the high volume centers have clearly demonstrated that they have much better outcomes. So, hip replacements, knee replacement, it doesn't make sense. Now, the sad thing is that's an old study now, so hopefully it has changed. But the vast majority of ACL reconstructions are done by surgeons who do less than 10 a year. And that is problematic. But yeah, the people who listen and they are in the metropolitan areas with the big centers there, then yeah, if you do decide, and that's the other thing, and I'm digressing a little bit here, but thinking back to my journey with my own ACL injury as a patient, the person who's best positioned to do your surgery or to provide the treatment, in general, is not always the best person to make the decision about or to assist you in your decision about what treatment to do. So yeah, but once you decide to do the surgery, then going with a high volume surgeon who speak to some of the former patients. If they have published the research, even better, because you know what to expect, how many return to sports, how many complications they have, and so on and so forth. So yeah, the large orthopedic centers in New York, I guess in Colorado, you have many top surgeons there because it's a state with a lot of active patients, and having a lot of active athletes out there means that there is a lot of ACL injuries. And that's how the surgeons learn. That's the reality. That's how clinicians learn, by seeing a lot
It's called
patients.
medical practice, folks.
That's
you
right.
Practice. It's and we're doing our best. But I was going to ask that final question, maybe, of, again, somebody in that situation outside of bare cross brace, these more new exciting procedures. The more traditional options are, again, cadaver, allograft.
In terms of the grafts,
In terms of the graft, yeah. So autograft, allograft, quad tendon, patella tendon, which is what I had. I don't know what if you want to share what you had, and hamstring graft. I feel like hamstring has gone less, quad maybe more. Patellar tendon seems to be less these days, just in terms of what's getting carried out. In terms of outcomes, I feel like patellar tendon has generally been shown to have excellent outcomes in terms of everything that comes long term. The bigger concern is those early short term, like kneeling for a patellar tendon graft, and things like that. Do you have any thoughts on how that's changed?
Yeah, no, that's another fascinating area, in itself, Bo. So it is highly geographical. So in the United States, yes, we do see fewer hamstring grafts that we see in other parts of the world. But in Europe and in Australia, the vast majority of ACL reconstruction, they utilize a hamstring graft. As you mentioned, advantages and disadvantages for each graft. The quadriceps tendon graft is becoming more popular, and the research so far is showing comparable outcomes to some of the more established grafts, like the hamstrings and the patella tendon. I also had the patella tendon graft, largely because, I had quite a bit of ligamentous laxity in my knee naturally, and then there was a research study that showed that if you do have, it is a graft that provides more stability, does not stretch out as much because of the bone ends, the bone blocks. It's a more rigid reconstruction. It doesn't pull out of the tunnel as easily, and it provides better healing, bone on bone healing. So there are advantages for each one of them, but it is a more painful reconstruction, and it does predispose the patients to a higher possibility of patellofemoral pain or even patellofemoral osteoarthritis. I guess the big decision. So, but going back to what we were saying earlier, is you should go with what your surgeon feels more comfortable with. Don't force your surgeon to do a graft that they haven't played with before, or they have very little experience. But yeah, definitely, I would say in the young, active athlete who wants to go back to sports, the allograft is not the best choice. It does consistently show a higher rate of re-rupture.
Yeah. Thank you for that. I'll throw one more, hopefully not too big one at you. It is kind of a big one as I'm formulating it in my brain, but one of the prevention strategies that's talked about is an imbalance, and something we look at as we get athletes closer to return to sport is quadriceps to hamstring strength balance. I believe 3-2 quad to hamstring kind of is generally the recommended happy place. Hamstrings for and correct me if I'm wrong, is the mechanism of the hamstring, the action that it's able to do is kind of simulating and working with the ACL, in that it's preventing anterior tibial translation and helping with some of the rotational components even. So in terms of general fitness, in terms of having had an ACL reconstruction myself, building that general fitness, working through full range of motion to try to hopefully avoid arthritis. That's my big one of my biggest strategies is saying, yeah, I'm going to be as strong as I can through as deep of a range of motion as I can. So quadriceps to hamstring ratio, in terms of general fitness, I find a significant amount of humans in the clinic, in every aspect of life, are lacking posterior chain strength, hamstring strength, glute activation, proper firing muscles. We can go deep into that rabbit hole, but just from a big picture, how much does quadriceps hamstring ratio play into this? Where again, most people, you think of F45 classes, people tend to be doing short squats, 45-degree squats. They're overloading the anterior chain. They're getting patellar tendon issues. They're getting patellofemoral pain syndrome, all these kind of things. A lot of runners, a lot of anterior chain type issues. So I use it. I use this posterior chain activation concept for almost everyone I see for any kind of lower body program. But the question goes over to the ACL: how much preventative use is there if we say, hey, let's get better at deadlifting, go figure. And also for post-op recovery, where again, a lot of physical therapy clinics do not have a lot of equipment to get stronger than a black TheraBand or maybe a 20-pound dumbbell, if they're lucky. I had to bring in my own 53-pound kettlebell to the clinic just to give them something to get a little better sense of some weight. So yeah, sorry for that long, kind of not super clear question, but quadriceps hamstring ratio, how important is it in your perspectives? Where does it fit in?
Yeah, no, that's quite a bit to unpack there, Bo, and I think you've answered everything. I don't know how much to add there, other than to say that I'm not going to go too deep into the biomechanics, especially at the end of this show. We don't want to turn the audience away already, but at least in theory, yes, the quadriceps being at the front of the knee, they are antagonistic to the ACL because when they contract strongly, they tend to pull the tibia forward, which is what puts stress on the ACL, while the hamstrings, they are protective of the ACL because of the back of the knee. So they keep the tibia, they prevent the tibia from sliding forward. Now, the problem is that most of ACL injuries, they happen with the knee close to knee extension. So in the last, 40 or even 30 degrees of knee extension. Well, and this is the range where the hamstrings are particularly ineffective in pulling the tibia posteriorly, simply because the angle, it just doesn't work. So they would need a very gigantic contraction in order to prevent the tibia from sliding backwards. But you link that to osteoarthritis, and again, that is the holy grail after an ACL injury. How do we keep our patients active for as long as possible without symptomatic knee osteoarthritis? And Donald Shelburne and his group, they have one of the best databases of ACL patients out of Indianapolis in the world, and they have shown that there's a few things you can do to prevent knee osteoarthritis. Normalizing your range of motion. So, even, just making it as similar to the other knee as possible. And that includes hyperextension. Some of the PTs are quite hesitant to try to regain hyperextension because it does indeed put a bit more stress on the graft. But again, the research has shown that those patients who have 10 degrees of hyperextension, you should aim, gradually and carefully to regain full range of motion, including hyperextension. Full range of motion in terms of knee flexion, it took me a couple of years. I mean, I had a more complicated injury and multiple surgeries, but it did take me a couple of years until I was able to sit on my heels. And that's what we should aim for our patients, full range of motion in both flexion and extension. And then, as you said, keep active, keep your legs strong. Now, the exact ratios, considering the challenges in terms of measuring it accurately, unless you have access to an isokinetic dynamometer, there are tools out there like that can now measure that better than we had even like 5-6 years ago. So there are some dynamometers that are more accessible to the clinics, but again, not all the clinics have that. Yeah, keep your quads strong, keep your hamstring strong. But also, your biomechanics, and maybe that's a topic for another podcast. But another area where we fail as clinicians is to finish the rehabilitation at the end, right before we return the patients to sport, by doing a proper biomechanical assessment and then looking at whether it was excessive knee valgus or trunk control or asymmetries from side to side, or do they land with their knees too straight? What caused the initial injury, because there is predisposition there in terms of biomechanics, and correcting these or providing a program that allows us to correct this to our patients. And I really hope that if we do that systematically, we can reduce the risk of re-injury. So yeah, it's going to be exciting in the next few years to see how these things evolve. But both, thank you so much for the opportunity today, and for all that you do to make the science and the research accessible to a wider audience. We do need more of that because, you know, we as clinicians and researchers, we live in our own bubble. But again, you know, this information needs to get out to the rest of the world, to the people who make the decisions, you know, to the patients and their families. And yeah, we you know, with the work that you do, you know, I think that is this translational piece of research and the implementation aspect of research that is lacking in general. And thank you for filling this gap.
Hopefully, I'm working on it. Always working on it. I'm sitting in the bottom of a squat right now for my own knee health.
There you go.
Third world squat. So thank you for that reminder. Always got to keep that bottom of the squat. Ooh, leaning forward. Thank you, sir, for joining us from Australia. What time is it there?
It is 10:43 in the morning.
In the morning,
Monday
yes. Morning. And I'm about to go to bed. It is 7 p.m. It's about to be 7 p.m. here. So that's the wonders of time zones, folks, if you're not familiar. But the earth is somehow flat is what I've heard. Anyway, as you said, a discussion for another day. Thank you, Evangelos, for joining us. And if you have any other things for folks where you want to direct them in terms of ACL, are they Googling these new clinical decision-making tools, or should we try? I'll do my best to put them in the show notes. But again,
I can send you the links, Bo, and then you can put them in the notes. So yeah, people who want to access them, they can. And again, you know, they can. I'm on Twitter at evpapas with double P. If they want to follow there, my very rare posts, or on LinkedIn for the clinicians and the researchers who want to connect there. I obviously, we both love talking about ACL injuries. So yeah, let's keep the discussion going.
All right. Thank you, everyone. Hope you got at least 1% better today and you can avoid one of those big injuries. And if you're in that situation, feel free to reach out to myself where we can talk about some of the decision-making tree and maybe get you to some of those tools and how you can use them. Again, we can translate if it doesn't fully make sense to you. That's okay. So I hope everyone's doing great and avoids those ACL injuries.